and welcome. My name is Manesh Patel, and this is the Stroke Management Evolution Exploring Factor 11A Inhibition, a Medscape live event. Thank you all for joining. So as I said, my name is Manesh Patel. I'm professor of medicine and chief at the Division of Cardiology at Duke University, and I'm joined by a friend and a colleague today. I think we're going to have a great discussion about this topic. I'll have him introduce himself. Ashkan.
I am Ashkan Shoamanesh. Pleasure to be here. I'm a stroke neurologist at McMaster University.
So an actual live event with a cardiologist and a neurologist, you can't find that every day. So hopefully you guys will get something out of this as we talk about what we think and how we learn about stroke management. Our topics for the next 15 minutes in this live event are to go through kind of current approaches to stroke management. Ashkan and I are going to go through it. I'm going to learn a little bit like you all probably on what's the state of the art in stroke management, and then understand a little bit about with that management, how does factor 11 inhibition work? Why do we think about that concept? Is it meaningful? Where are we going with that? And then we're going to sort of top it off with where are the existing data and trials going in this, and what can somebody in practice or patients or even people doing the studies think that's coming forward. So it should be exciting. Ashkan, again, thanks for joining. Let's get started. I guess I'll start by asking, and maybe just going into this first before I get into it, is just to say, as a cardiologist, I take care of a lot of patients who have a lot of the risk factors for stroke. We think a lot about heart disease, and we think more and more about stroke, and about 88% of strokes that people have are ischemic strokes. So the first message, we think a lot about bleeds in the brain and strokes, but about almost 88 to 90% of those are ischemic strokes. And despite all the things I think and care about with atrial fibrillation, which I do a lot, among those ischemic strokes, about 75% of those are not embolic strokes. They're not caused by cardioembolic sources, and so they're likely coming from athero in small or large vessels. And then, another piece for our audience to think through is that the AHA had this sort of prognostication document sort of thinking about with Karen Joint Maddox and Drew Kazi about where's the future of cardiovascular risk factors by 2050, what's the projected burden? And it's estimated by 2050, 61% of people in the United States will have some form of cardiovascular disease, with some of the most important forms, including hypertension, obesity, and some of the risk factors that lead to not just hypertension, obesity, and cardiovascular disease, but most importantly, strokes. So finally, 1 in 4 of the people that we see that have had a stroke, they've had a stroke before. So there's both primary prevention of stroke and secondary prevention of stroke, and how do we help it? So with that sort of background, Ashkan, maybe you can tell us about what's standard of care today for the management of patients with stroke.
Yeah, 100%. And I think it goes without saying, as you indicated, that the global burden of death and disability from stroke is huge, and it's only going to expect to be increased over the coming years with aging demographics and some of the demographical changes we expect globally. We're going to focus today on non-cardioembolic ischemic stroke. This accounts, as you mentioned, for about 3/4 of ischemic strokes. And the approach in trying to prevent a recurrent event in these patients is actually kind of very similar to what you're used to in trying to mitigate coronary disease-related major adverse cardiovascular events. And that's really a multi-pronged strategy that includes antithrombotic regimens, lipid-lowering treatments, blood pressure control, glycemic control, and lifestyle modifications. What's a bit different in stroke versus coronary disease, of course, though, particularly when you're looking at the categorization of non-cardioembolic ischemic stroke, and you've already alluded to this, Manesh, is that there's a bit more heterogeneity in the underlying etiologies, right? It's not all athero. There is also some small intrinsic cerebral small vessel disease that contributes to lacunar stroke. There is this category of cryptogenic stroke or embolic strokes of undetermined source, which is kind of a mixture of different etiologies, although the more we understand about it, the more we think non-stenotic atherosclerotic disease contributes to the majority of it. And then there's this weird and wonderful kind of things like vasculitides, dissections, and so forth. But really just kind of sticking to those main 3 categories of non-cardioembolic ischemic stroke, either cryptogenic, lacunar strokes, or large artery atherosclerotic disease. Our current kind of guideline recommended treatments can be broken down in that when we are thinking about antithrombotic regimens, there's been several trials now, the POINT trial, the CHANCE program, THALES, and then most recently INSPIRES, where we've learned that in patients who present with non-disabling ischemic strokes, so NIHISS stroke scales of 5 or less, or high-risk TIA within 72 hours, that really the standard is DAPT for at least 3 weeks, maybe as high as 3 months, but most of the benefit is within that first 3 weeks, followed by monotherapy. Now, in patients that have severe intracranial atherosclerotic disease, the standard of care is actually DAPT for 3 months, irrespective of the size of that infarct, followed by monotherapy. The only caveat here is to remember is that actually we've never had a randomized trial demonstrating that this regimen is better than monotherapy in patients with ICAD. It's really was the antithrombotic regimen that was used in the Sampras trial, which was comparing medical management to stenting, where stenting was shown to have a higher risk of stroke than medical management. And based on the underlying benefits that we've seen in cardiology with DAPT in patients with athero, and the fact that the Sampras medical management arm had less events than historical controls, we've adopted this in stroke.
Yeah.
And then, go ahead.
I was just going to say, I mean, I think those are important points. And one might say, if I put this together, is that we're using DAPT post-stroke, but we're using it based on some limited evidence, and otherwise everybody gets sort of monotherapy. Is that fair?
That's fairly fair. For the typical kind of non-cardioembolic ischemic stroke patient, that's quite fair. And the DAPT regimens that are most widely used are going to be aspirin with a P2Y12 inhibitor, either clopidogrel or ticagrelor.
And if I think about it on this slide, but also just from a cardiovascular perspective, we do a lot of secondary prevention, and we do it the same, whether the athero is in your heart or in your brain or in your legs, lipid-lowering blood pressure and glycemic. And we may not spend a ton of time on that because we're going to be thinking about really where the variability is coming, which is how do we get better than antiplatelet or mixture of antiplatelet therapies for stroke? So one message might be, do everything you're supposed to be doing for primary and secondary prevention anyway, but when somebody who has a stroke, there's a lot of sort of thought and possible unmet need in this antithrombotic regimen.
Yeah, I agree. As you can see, despite our best guideline recommended treatments, the risk of stroke remains high in these patients. It's 6% at 1 year, and 1 in 5 will have a recurrent event at 5 years. So there's definitely a lot of improvement we can have. And one thing that hasn't really penetrated into our standard of care of these non-cardioembolic ischemic strokes are anticoagulants. And often is because any benefit, if at all, was seen was offset by bleeding. And Manesh, do you want to maybe just take us through some of the anticoagulants that have been used historically, their targets, and how maybe factor 11 inhibition can take us a step further?
Yeah, I don't want to give everybody too many seizures at home when they're looking at the coagulation cascade. You don't log in to see that every day. But just to make it, straightforward for most of us who are taking care of patients, is we grew up in the warfarin or vitamin K antagonist cascade, just to go through the anticoagulation affecting 2, 7, 9, and 10, and heparin and direct thrombin inhibitors and others having a relationship between factor 10 and factor 2 or direct thrombin. So we've had oral and IV versions. And the 10A inhibitors were a big step forward, the DOACs. And so it's on that background, I would just say that the concept of factor 11 inhibition starts, which is, as you said, one of our keys is that almost all anticoagulation that we've used to date has had this thing we've been trying to balance, which is, can we prevent clot from happening while we don't have too high a risk of bleeding? And you can see through the decades of the coagulation cascade innovations that we had on the last slide, 10As were central and a little bit more specific than vitamin K antagonists that are across many ways. And so they won in atrial fibrillation and in other places, but they didn't win in secondary stroke prevention. And they weren't studied there because of this risk-benefit analysis. And so it's on that background that the concept of factor 11 inhibition comes about. Just two statements, and I'll see what your thoughts are. First, factor 11 inhibition, it's upstream from 10, and it's actually getting activated by contact inhibition. And so the idea is that you'll have a normal pathway where you have hemostasis, thrombin generation, and then that thrombus propagation happens through contact activation with 12 going to 11, 11 getting activated, and then starting a process. And so if you can inhibit that thrombus amplification step, you might still get hemostasis but prevent pathologic thrombus. I'll call it the holy grail of preventing clot without bleeding. Obviously, we have to do studies to do that. And so that's really what the focus of factor 11 inhibition has been. Any thoughts about that before we get into sort of where the data is for everyone?
No, I have to agree that it's a really compelling story for factor 11 inhibitors in that we can uncouple hemostasis from thrombosis. And there's so much both clinical and preclinical data that is consistently supports this theory, and I'm excited to see what the clinical trials demonstrate once they're completed.
Yeah, I should have highlighted, as you highlighted there, that, why did we come about with this idea? Well, there were people with a genetic deficiency in factor 11 who don't seem to be having more bleeding and seeming to still have less thrombotic events, even into elderly age. So that, I think, led us to that. And so, maybe in our last 5 minutes here, we'll think about the therapeutic approaches to this. There's, as I said, factor 11 inhibitors and factor 11A inhibitors exist. And so there are some thoughts here. I would say that first of all, 11 has to be activated. And so you can imagine that there are monoclonal antibodies or, actually ASO compounds that can go and interrupt factor 11 getting activated to factor 11A. And then it's that activated factor 11A that then leads to the downstream coagulation. So upstream, there's some monoclonal antibodies and ASOs. And then there are 11A inhibitors, as you can see on this slide, some of which include asundexian, milvexian, and there's some antibodies that can be there too. So there are multiple groups with multiple ways to do that. And I guess, what people would be wondering is sort of what's the state of the science and the state of the studies going on there. And maybe, Ashkan, I'll go forward one and then come back and maybe have you tell us a little bit about where we are with the preclinical, like the phase 2 data, and then maybe the phase 3 ongoing studies for stroke prevention.
Yeah, for sure. So what's really unique about the development of factor 11 inhibitors is that this is the first time that in phase 2 we've had dose-finding trials for stroke prevention specifically. Previously, we've adopted doses that were shown elsewhere, like in the DOAC development story, it was really VTE prophylaxis in patients who had total knee arthroplasty. Those doses then were used in AFib and subsequently stroke. Here, we really have those finding studies for stroke. And there was 2 trials that were conducted out of my institution, the PHRI. One was axiomatic SSP, and then the other one's Pacific Stroke. And again, kind of consistent with what we've seen over the development of the factor 11 story is consistency in the results. Both these trials were neutral for their primary efficacy endpoint, but that was due to the lack of effect on covert infarcts on MRI that were predominantly due to small vessel disease. And when those were removed from a primary efficacy endpoint, in patients, the outcome of ischemic stroke was numerically reduced with these agents, and significantly so, at least in Pacific Stroke, in those that had some degree of atherosclerotic disease on vascular imaging. And this has really led to excitement about the ongoing phase 3 trials, which include Librexia Stroke and Oceanic Stroke. Both these trials are enrolling more than 10,000 participants, so they're going to be very large stroke prevention trials. And they're targeting the use of these factor 11 inhibitors versus placebo on top of background antiplatelet therapy. And really, the safety signal from the phase 2 trials was also very compelling, that we can use these agents on top of background antiplatelet therapy without any excess in major bleeding or intracranial bleeding or hemorrhagic transformation of infarcts when used early post-stroke.
Yeah, I think that the last point you just made there is really important for those, sort of what are like the big take-home points in all of the factor 11 studies, whether it's in the phase 2 VTE studies or VKA studies, or in the AFib or even the stroke studies. We see that almost across even elevated doses, that factor 11 doesn't seem to have a classic dose response for bleeding, although we might see some efficacy signals, and that bleeding rates seem to be much lower than comparators. In fact, sometimes with placebo comparisons, close to placebo on top of antiplatelet therapy, so that we hope that this promise of having less bleeding while still being able to have a thrombotic effect on antithrombotic effect will be valuable. And we're going to see that in maybe the most important real estate we have, and that's hard for a cardiologist to say, but obviously the brain matters a lot, and stopping clots in the brain while not having bleeding is potentially why these big programs are going to make such a difference.
You can transplant a heart, but not the brain yet.
We've tried. People have tried for me, and it hasn't always worked out. But the point is that you're absolutely right. You have very little to do. So, I want everyone to recognize our sort of take-home points. Where really appreciate you all joining. There's an opportunity as we see the evolution and the idea of going from broadly inhibiting the anticoagulation cascade to getting really, really personalized and specific. Factor 11 inhibition opportunity is there. Stroke is obviously a big opportunity to do that. Any final thoughts, Ashkan, before we make sure people sign off and make sure that they get CME credit for joining us?
No, thanks so much. I really enjoyed our discussion. Really exciting field, and stroke is just a piece of the puzzle. We saw that there's a large amount of trials that are ongoing that we haven't had a chance to discuss in other targets as well.
Yeah, so I'd say that, you know, the evolution of the Goldilocks, stopping clotting, not bleeding, actually personalized therapy coming, the science will hopefully catch up when we'll see it here shortly. Thanks everybody for joining, and make sure you fill in the CME.